All right. You might see a pop-up on your screen. If you can just accept that, we would appreciate it. And unless there are any last-minute questions, we'll officially begin tonight's event and turn it over to President of the University, Dr. Neeli Bendapudi.
Good evening, everybody. It's wonderful to have an opportunity to see everyone. I have to say that for an extrovert like me, seeing so many people on my screen just boosts my mood. What can I tell you? I wanted to thank you for joining us today. This is a very, very important conversation. And you'll hear more about the Co-Immunity Project and the incredible work that's being done. And this work comes out of our Christina Lee Brown Envirome Institute at the University of Louisville. And of course, this is in cooperation with several major hospital systems, from the James Graham Brown Cancer Center, Norton Hospital, Baptist Hospital, UofL Hospital. And we cannot forget the support of our friends at JHFE. The Jewish Heritage Fund for Excellence has been an incredible partner to us on so many issues, and this is no different. So we appreciate their cooperation. You'll hear more about the Envirome as we go on. I have to tell you, I'm a believer. I love this because it's the circle of health and harmony. It's the new vision for health. It's the idea that we need to look at global health in a holistic manner. And by that, I mean, we really pay attention to the physical, the financial, the psychological, the spiritual health of an individual. The other thing that's really unique about the Envirome, which actually resonates deeply with me, as someone who grew up in India, this is something that I grew up believing, which is this notion of biophilia, that really there is something to be said about the human within the natural environment, and that what's around us has a profound impact on who we are. So I would like to tell you why this research function is so important to the University of Louisville, especially the kind of work you will hear from Ted and Aruni in a few minutes. University of Louisville is one of now about 130 universities worldwide that have an R1 designation, or Research 1. Many of you follow athletics, and you certainly know D1, D2 when it comes to athletics. It's the same notion around research, where we are an R1 institute. The other interesting thing about the University of Louisville is we're also one of a few hundred universities that are ranked as highly community engaged. The same Carnegie rating system doesn't call it C1, C2, but if they did, we would be C1 in that respect. And there's only 69 universities across the whole world that are both highly community engaged and very high on research activity. And this particular stream of research captures that perfectly. So I know at the Envirome and at the University of Louisville, we talk about being in a city, meaning we have the whole urban campus as our laboratory. It's the urban lab concept. And so today you'll hear more about all of those ideas in action. So I'm excited for you to see this. My first job is to introduce Ted Smith. And I bet all of you know Ted. He is, above all, a good man. I hope that's okay to say. He's a good person and someone that I really appreciate and admire for that. He is an associate professor of our PharmTox department, pharmacology and toxicology. He's a deputy director of the Christina Lee Brown Envirome Institute, and he's the director of the Center for Healthy Air, Water, and Soil at our University of Louisville School of Medicine. The research that he does in that capability or in that capacity addresses the promotion of human health in urban environments. And it's incredible the background he brings to this, along with Aruni, because actually I didn't even know this, Ted. Every time I learn something more about you, which is that in many of these projects that require sensor and data technologies, for monitoring the ambient particulate matter, noise pollution, toxins in the air, etc. Previously, he was the Chief Innovation Officer for the city of Louisville. And before that, I won't go through step by step. I will tell you that his PhD is in experimental psychology from Miami University. He completed his postdoc studies at the MIT medical lab. As Mary Nixon told you, hour 14 on the calls for me. So please forgive me for the lisps and slips of the tongue. But Ted, the part that I didn't know is that you were co-investigator on the Neurolab Space Shuttle mission. That's what I say. Every time I learn something else about you. So I love that we are bringing all of these different capabilities together. And so with that, Ted, I'm going to turn it over to you to tell us what's gone on so far with the community project.
Great. Well, Neeli, thank you so much. Really appreciate that wonderful introduction. We tried to make some edits at the last minute to shorten them because we don't want the introductions to be longer than the presentation. But thank you very much. I'd be happy to tell you about my work with the space program, but it does involve astronauts throwing up, and that was my core expertise while I was at MIT. So I'm happy to move on to greener pastures at the Envirome Institute. So thank you again. Well, we've divided the labor this evening to introduce this project to you. In some ways, it's a little out of order to have me introduce this project because our next speaker, my boss, Aruni Bhatnagar, it's really his brainchild. But I think it's appropriate for Neeli's introduction to reflect for a moment on how we might maximize this research university in the city, right? An urban research university, a metropolitan research university, to really help tackle the issues of the day. And so our journey to this project that we call the Co-Immunity Project, and I think I'll share my screen, not because there's going to be a test or that I expect anybody's going to take notes, but just because some of the visuals may be helpful. Our journey into the Co-Immunity Project actually has a lot of local championship. And so I see Mrs. Christina Lee Brown in the window there. As our community was traumatized, as all communities were with this virus, we asked ourselves some big questions about really what was the nature of this threat to us all. And I won't get into a political speech about, you know, the role that the CDC might have played in a different universe or different time, but many of us feel that we were sort of caught off guard about what we didn't know about this virus. And Dr. Bhatnagar, in many conversations, we decided that this would be a great opportunity to partner with many different parts of our city to answer the question, where is this infection? Is it in certain places? How is it trending over time? Are there certain populations that are more vulnerable than others? And, you know, many of you, I'm sure, are keeping track of all the various news over the many months about this. But, you know, back in, you know, April, we didn't have very many answers. And we launched this project that we call the Co-Immunity Project in 2 phases. The first phase was focused on the healthcare workers, and an important partner to the University of Louisville in our community for this work is the Louisville Healthcare CEO Council, and Tammy York-Day is executive director of that council, and it really is the collection of many of our leading healthcare companies in our community. And when we all got together to talk about the importance of protecting and having an available healthcare workforce, we very quickly agreed that that should be the first population that we keep track of, and we understand who's infected, who's been infected in the past and survived infection and may have antibodies, those big questions. And so let me see if I can advance our slide here. We did this phase 1. And I apologize if this doesn't work. There we go. So the phase 1 of the Co-Immunity Project, looking at the healthcare workers, we just completed the first round of analysis with the healthcare workforce. I'm sharing today results from the University of Louisville hospital health workers. Baptist Health and Norton were involved. I don't have their data to share with you today, but you know, here's a first sort of top level snapshot. We issued a press release about this last week. I guess most of us may not be surprised that the level of infection in our healthcare workforce is low. And so we found only 2 people that tested positive in our exhaustive, sampling of that workforce. And only 1% of that workforce appears to have been infected in the past and shows antibodies. And so it's a good news, bad news story for us all. The good news being, all those protective measures that our healthcare workers employ are effective. These are individuals who are at great risk. They have the highest risk profile likely in our community because they're obviously treating and in close quarters with patients who are positive. And so that's the good news, that they're good at their jobs and that their protection works. I think maybe the bad news is, we as a group, we don't have a lot of immunity to this infection. So we have to remain very, very vigilant. This healthcare workforce is vulnerable and really needs to continue to practice all those good protective behaviors. We'll continue to follow these healthcare workers for many, many months. Those who have tested positive in the past, we're interested to understand the progression of their immunity. So do their antibodies last, and are they protective in the future? These are still open questions for the science community. So that's phase 1. Then phase 2, which is a very ambitious project, is essentially to partner with the city. So I said we partnered with the Healthcare CEO Council and the healthcare industry. The second phase is partnering with our city overall to understand what that infection has been in our community. And so to do that kind of work, we teamed up with a great contract research organization called WestStat. They do a lot of work for the CDC, managing various cohorts for various disease studies. That team, together with the city, we developed a plan to randomly test 2,400 people across Jefferson County. And without getting into the weeds on how these kinds of things are designed, just know that what I'm showing you here is a simple graphic of the different Louisvilles within Louisville. And so we have, no surprise to anyone who lives here, very different complexions, different makeups of people across our community. And when you look at them statistically, they sort of come out to be, 4 Louisvilles. And so when we're sampling, we want to make sure we have good representation from the 4 Louisvilles, so that when we say, well, how far has this infection gone? Where are there problematic areas? We can answer that with a representative analysis. This is not unlike really good political polling, where you'd want to be very, very careful to make sure that you had a good representative sample when you do this work. So last week we finished the first round of community sampling. So that means, pulling 2,400 people out of our entire county, getting them all through a drive-up testing or walk-up testing facility, and get them in and out in 5 to 7 minutes. We did that. It was very tiring work. I'll give you the credits later. Lots of people involved. And then we'll pick up and do that again 8 weeks from now. And we will keep doing that to establish a barometer of infection in our community. So that's a really important part of the work, is not just the people who come to the hospital or come to the doctor feeling sick, but to get a good snapshot of everybody. There are many people we know who are asymptomatic and infected. How will you meet those people? And, we would argue this is one of the only ways you will meet that particular population. Then slightly more glamorous, right around dinner time conversation is an important flanking part of this phase 2 community work. And it happens to be a part of the work that I lead up. And this is focused on how we can use our wastewater, so our sanitary sewer system, to keep track of where the virus is. So it turns out this virus is shed through fecal matter and is detectable in the sewer system. And we have been partnered with Arizona State University, who's been working in this field for a long time. Before COVID, looking in sewers for lots of other interesting biomarkers. When COVID-19 appeared, they were a great partner to get us up and running quickly. So we work with MSD here on the ground. So again, more local partnerships. So with MSD, they give us access to essentially sampling points that are mapped to those same places I just showed you where we're sampling out of noses. And we hope to, for the country, help establish kind of a lookup table, if you will, of how many copies of the virus you pull out of a particular part of the sewer system and how many people that likely represents infected in that part of the community. Both of these aspects of the project are in the city's COVID test plan. So this is part of the mayor's approach to keeping track of the coronavirus. And we are a partner then to all the other testing the city does, and we exchange data with the city to enrich the conversation. So if we find a place, maybe through wastewater, that appears to be threatening or concerning, Dr. Moyer can dispatch more community testing into that area or employer-based testing to get to the bottom of it. I have here just a fun graphic published by Yale about a month ago, where they show that what you can detect in sewage seems to lead what they see clinically by about 5 days. And so, you know, that's the city of New Haven essentially, and what they were able to pull out of wastewater, and then what they saw in clinical tests later. So it looks very promising. We're excited to develop this as a new area of clinical insight. It's a brand new field in many respects, and this virus has really made it pressing to understand how it could work. And just quickly, you know, these are the sampling zones. We have little green dots where we have sampling locations. Today, we're doing 15 sites once a week. Next week, we hope to be doing those sites twice a week. At our main wastewater treatment facilities, we're doing it every day of the week. So so stay tuned on that. We've been able to detect copies of the virus in different parts of our community, but we're going to reserve kind of releases and discussion until we have a little more data under our belts, understand what's a concerning signal versus something that we can just measure. And then, as I promised, the credits for the project. This is actually not a complete list of people who've been involved so far. There's probably another 30 names that in the scramble today, I didn't get them all on there. So my apologies to those folks who were an important part of the project that weren't listed. But a project like this is an ambitious project. It's an important project. It really does require a diverse, transdisciplinary set of skill sets. And I'm very proud to be an institution that has such a wide range of people with such diverse talents to make this possible. So that would be the sort of, let's call that the community part of the discussion. I hope that gives you a flavor of, you know, what it is to work in our city with partners in the community to do this work that can't be done just as a university. I mean, we require all these partners that I've mentioned in order to do this work, and they have all been tremendous and really are contributing to the science. And so we thought the next part of the conversation maybe could be led by my boss and colleague, Dr. Aruni Bhatnagar. And so I will introduce him, and I may choose to take the shorter route, even though, I mean, just mostly because we don't have another hour, but I mean, he's a very accomplished person. And if anybody wants the full version, they can call me. So Dr. Bhatnagar, one of my favorite people, and the reason I'm at the University of Louisville right now, is widely regarded as the person who spearheaded the field of environmental cardiology. And just the quick version of that, we used to think of cardiology as a plumbing problem, right? Pipes break, leak, corrode, fix the pipes. Dr. Bhatnagar and many colleagues over the last decade and a half introduced the importance of what we have in our ambient environment, whether that's air pollution, whether that's smoking, and how those environmental factors change heart disease. And it's a remarkable contribution, and it's one that pays dividends to this day. So that was the environmental cardiology pitch. Dr. Bhatnagar is the Smith and Lucille Gibson Professor of Medicine at the University of Louisville. He spent more than 25 years studying the impact of toxic substances, tobacco, smoke constituents, and environmental pollutants on heart disease. He's a graduate of Kanpur University in India and received his postdoctoral training at the University of Texas Medical Branch in Galveston. Dr. Bhatnagar is known for his pioneering work on the metabolism of toxic substances in ambient air and tobacco smoke and how they affect the development of cardiovascular disease and diabetes. He's published over 280 research papers, commentaries, and review articles, and 20 book chapters. His research has been supported by the National Institutes of Health, the Environmental Protection Agency, the U.S. Department of Defense, and the American Heart Association. These are all blue chip organizations. He currently serves as the director of the newly created Christina Lee Brown Envirome Institute, and he also is credited with founding our Diabetes and Obesity Center, and he is the director of the American Heart Association Tobacco Regulation and Addiction Center. Dr.
Hey, Ted.
Bhatnagar, yes.
As Aruni's boss, I want to take the privilege of saying one more thing about. I won't go on and on. I was trying to say, I want you all to know how incredibly fortunate we are to have Aruni here. And I mean that so sincerely across the whole university, because in academia, we talk about some people as the triple threat. They can do incredible research. They're incredible mentors in the classroom with their students. They are always happy to serve the greater community. And this is definitely, without question, one of my favorite people as well. And I just wanted you all to know that you are in for a treat today, because you're hearing from someone who is not just a local expert, a national expert. This is truly a global expert in this field. So Aruni, I'm just so grateful you're here and so proud, and take it away.
Hello, good evening, can you hear me?
Yes.
Okay, well, first of all, Neeli, thank you very much for that very, very kind introduction. I'm taping it and I'm sending it to my mom this evening. So she needs some convincing, but also thank you very much for that introduction and the fabulous warming up and opening act. I don't know what's left to say, but I would just add a few remarks. First of all, I want to point out that we sort of started on this journey about 2 or 3 years ago with Christy and Ted and I, sort of three lonely crusaders. We have all worked and tried to understand that environment has an important influence on human health. But the question is, how are we going to study it and how are we going to address it in all its complexities? And then we needed an administrative umbrella, and we are very fortunate to have at the University of Louisville sort of receptive administration and receptive colleagues who let us sort of put our stake in the sand here and said we will develop and this as an epicenter of this new idea, a completely new vision of health, in that we are not overtly focused on an individual and telling them you are unhealthy because something's wrong with you and that's what we need to fix, without looking at the large number of factors that contribute to a person's health and well-being. And as we have learned over the years, how important it is, that type of the environment people live in and the places they live in, the type of food they ingest, and even the type of friends you have. I mean, if you have friends with bad habits, you have 50 to 40% chance of getting the same bad habits, right? So our social circles, our environmental conditions, the nature around us, all of that contributes to these many forms of health, which is just not physical health, but also sort of mental health and economic health and cultural health. And so we cannot be healthy without our community being healthy. And so this was the idea that we started with, and to create this an entirely innovative, unusual entity within the University of Louisville. And we have just begun. I think this has just been 2 years, and we have a lot of ground to cover yet. But as we were progressing in a journey, we were all hit by this pandemic, and which sort of really made us do two things. One, it made us examine our relationship with our community. We know that our health is important to us, but equally important is the health of everybody around us, and that we cannot be healthy if everybody around us is not healthy. So we learned the importance of community, or sort of it reinforced the importance of community, of who we really are and how critically all our health depends on each other. And the second thing that we learned was that we need to participate in this sort of enterprise. We cannot stand on the sidelines and see this pandemic decimate our community, ravage our nursing homes and our prisons and our people in the schools, and say we study heart disease. That's not something that we do. So whatever little expertise and background we had, we marshaled them to this larger cause, and to be able to then really address most of the most critical issue, which was first to figure out how much of a risk is this pandemic to our healthcare workers. And as Ted explained, we went to our healthcare workers and they were fabulous. We gave them little kits so that they could prick their own finger. They collected their own sort of swabs, and they brought it back to us. And we were stunned. 1,400 people participated. And we finished that. And we are going to repeat it. Every 6 weeks, we're going to repeat this reevaluation of healthcare workers. We think we need a surveillance and vigilance in what's happening to them. We cannot, under any circumstance, sort of afford that they would get infected and be sick and put at risk. They are our heroes who have really carried us through, not only at the University of Louisville, but across the world. And the least we could show with our appreciation would work hard enough to ensure their safety and well-being. And so I think that is in keeping with what we actually thought initially what Christina Lee Brown Institute should be doing. And so we took to the task, and we will keep doing it. But we also need to monitor what's happening with the community. We have lots of different sites. We had, Kroger's and Walgreens that you can drive up to and get tested. But if we just keep doing that, we will never get a grasp of the true extent of the pandemic, how many people actually are sick, where there are people in different parts of that. There are people living in different parts of the town would have to have different rates of the disease. And so we cannot simply be sitting back and say, whoever comes to our door, we will then go back and measure their risk and look at how infected they are. We need to reach out to people. And so we did the Co-Immunity Phase 2 project, which we set out to enroll 2,400 people, and which we did in a week. We enrolled 2,400 people. We have at least 1,200 people still on a waiting list who want to get tested, and we couldn't because we had to close the study for the time being. But again, we will open that back again in about, I would think, 6 to 8 weeks, and then we will keep doing it as long as you're funded to do it, at least till December. So part of this vigilance and involvement with the community is, in our view, in keeping with the core beliefs of the Envirome Institute and the reason that we created this entity to begin with. And to be able to be there, even if we are the last act standing, to be there for the community. And once we have that relationship, that we can grow that to understand a myriad sort of environmental factors. We know that there is great need, as we have learned quite starkly in the last few weeks, that there has been a group of people that we've been ignored for a long time, and that we need to be participating and be involved in the needs and the necessities of all the communities that are there in our city. But more importantly, we have to develop, as I keep saying, develop and create new knowledge. That if we just do good work within our community, which we cannot tell anybody because nothing unique to say about it, except for the goodwill that's created, and there is no new things that we have learned from this activity, that we have or not have accomplished our mission. So that's why the Envirome Institute is an academic institution which primarily is committed to creating new knowledge. And therefore, we think that by doing this work in a unique way, we might be able to provide a national model. We know there's a great dearth of actually a coordinated effort nationwide. And so this might serve as one way of surveying and monitoring a community and the spread of this disease. So it's not only just the coronavirus for now, but there may be other future outbreaks that this could be a model. When we first started this, there was no randomized testing in the country, and so I thought this is the most reasonable thing that appeared to me to do. And I called up Ted and said, Ted, I have this wild idea. And if you think this is crazy, I wouldn't talk to anybody else. And so he said, no, let's explore this further if it has any legs. And then we went to Christy, and she was extraordinarily supportive and said, no, you guys need to do something. And she reminded us it's not only part of our academic mission, but as our obligation and duties as being members of a community, that we need to do all that we think that was the best thing to do. So we did the study, and I think once we write it up, that it would be a model for other communities to be able to test it. I think we're trying to look at both the individual level of infections. We are looking at the sewage, and when we put them together, we will have, in our estimate, the tightest grasp and the grip on the level of the epidemic that's sort of unfolding here. And so not only will this sort of address the current problem, it would also then develop into future projects. For example, we're trying to set up in phase 3 sort of a follow-up with all our participants who've tested positive to understand how they got infected, what happened to the infection, where they might have gotten the infection. So we will have all this data so that in fall, if suppose there is a second wave, that we are not standing in the middle of the road like a deer in headlights, that we would know what to do. We would know what rates we had. We would know if they're increasing. And like Ted was showing, we will have some advance notice if you're following the sewage that, okay, if there are rates of the infection increase in the sewage, that they could also be increasing in the hospital sooner or later. So the more advanced warning that we have, the better equipped we would be. There is no excuse to be so clueless the next time the epidemic rises up again. We are, after all, capable of learning from our mistakes, and we're capable of learning from experience. And that's what we intend to do, to learn and to document and to make available to everybody else what we have done here, so that it could be a model for us. And then we could engage in a dialogue with people elsewhere. I know we have been in contact with people at Harvard Medical School. We've been in contact with people in University of San Francisco, Indiana, and other places, to see that what we are doing is nationally relevant and viable. So this would then, even after this is over, we would be able to use this experience to do more innovative and sort of insightful things. So one of the things we're thinking of, maybe as could be a phase 4, would be that we would have a clinic that would bring back all the people who've had COVID. We've seen some reports that people who have the infection, even when they recover, they have lingering health problems. Even people who are asymptomatic, if you look at the lung scan, there are fibrosis and nodules in the lungs, which they may not feel anything now, but as they age, it may progressively deteriorate. So we need to have a surveillance in which we monitor everyone who has had this disease, and we want to create this clinical facility available to everybody in Kentucky who can come, whoever had COVID, so that we can provide long-term care and follow-up. So things like, and then in the overall context, to go back to where we started, learn how the environment, elements in the environment affect our health and well-being, so that we can make all the decisions through the lens of health, and to be able to say what really good health means and how we can work all that we can to best to preserve it. So I would stop here and open to questions if you have any comments or suggestions.
Thank you, Dr. Bhatnagar. Hello, everyone. I'm Elia Fox, Executive Director of Development for the James Graham Brown Cancer Center. And this evening, I have the privilege of being our moderator for the question and answer session. As a reminder, if you have any questions, please type them in the chat box for our panelists. To get us started, we have some questions that were submitted during the registration. First, what exactly is antibody testing?
So when we have an infection, and anything, could be virus, could be bacteria, and when we have an infection, our body responds to that by making antibodies, which actually latch on to the structure of this microorganism and then targeted it for degradation. So this is our defense against any invading pathogen. And we have antibodies to a variety of things. It's the most exquisite and marvelous biological capabilities. We can make antibodies to over 3 billion molecules. So we have the capability of protecting ourselves, but it takes time. And sometimes when you have an infection, you don't have enough time to make enough antibodies to protect ourselves in the first insult. But once you have the antibodies, a subsequent insult, you could easily ward off because you have a resistance against it. And so, but the antibodies are specific. They're specific for each microorganism because they are so exquisitely well tailored. So therefore, those are required for protection. What vaccines do is to give you a boost of antibodies so you already have pre-existing immunity.
This might be a nice time for a quick advertisement for our Center for Predictive Medicine. Aruni, do you want to just quickly talk about what serious antibody work looks like versus maybe some of the stuff that's been in the past?
Right, so there has been a lot of different antibody kits that have been tested, and some are much better than others. And so those are kits that need to be turnkey and operated fast. The really gold standard is to do something what we call ELISA. And then we have in our university the capabilities. We have a BSL-3, a biosafety lab, which will be one of the 12 in the entire country. So we can not only test how many antibodies you have, we can also test how strong they are. So for that, what we do is we take a cell, infected with the virus, and then put the antibody. See, the antibody can kill the virus. They call neutralize the virus. So we can get the levels of what is called the neutralizing, the titer or the level of the neutralizing antibodies. So we only our facility and few others in the country have the facility to do that.
What is a randomized community sample, Dr. Bhatnagar, and why is it important?
Okay, so if, like Ted was saying, if you want to poll how many people believe that candidate X is better than candidate Y, you need to get the opinions of everyone. You make sure that everybody is included. And so in order to ensure that, we have to get a random sample of people so that we get people who are from randomly come up. So if we select people from different parts of the city, that be random, but it may still end up being heavily weighted to one or the other type of people. So it needs to be what we call stratified. So we have different, like Ted was showing, different parts of the city. So from each city, we have a random sample. So you want to ensure that everybody has a chance of being represented in the final sample, and that we have equal proportional number of people from each different demographic criteria that is representative of that area of the city. So that will be what we call a true snapshot or a true sample of what our community looks like.
And how many people are tested per round?
So for each round, surprisingly, we invite more than 15 or 20,000 people. We're testing 2,400 people. But and we will do that every round, and each round will be 8 weeks in apart. We have had such overwhelming support, response, that we might have to increase our number of people that we want to test. We want to create some sort of a mobile lab that we can go to people, because lots of people in our community cannot, don't have transportation and do not want to take public transport in this time. So we might want to go to their doorsteps and then get them to participate. So I think we would try to include as many people as possible, at least 3,000 people the next time around.
And are the test results being generated by using equipment that's already housed within the Institute?
Yes, so all of the test results are being generated at the Center for Predictive Medicine. Again, we are very fortunate to have support from the Jewish Heritage Fund for Excellence. They had pre-equipped the lab beforehand, even before the pandemic started. So we have all the facilities to do high throughput measurements of what we call PCR for the virus, and high throughput measurements of the antibodies. We provide our results of the virus testing within 24 hours and the antibodies within a week.
If we do not have an effective vaccine developed in the next 6 to 12 months, how do we move forward?
So that's the $1 million question. We all need to figure out how to move forward. We would have to live with this virus. There is no escaping it. We are very, very fortunate in Louisville to have had escaped the brunt of the pandemic. Our rates are very low. As Ted showed in a slide, out of the 1,500 healthcare workers we sampled, there were only 2 that are positive. but it would be trying to figure out where the infection is, rapidly isolating those individuals and preventing the spread, and then following all the social distancing guidelines. Of course, wearing masks. I think those sort of precautions are absolutely essential, at least for the next 12 months. Some people say it might last 2 years. We've been trying to get a vaccine for AIDS for 30 years. We haven't gotten that yet. So it's not a magic bullet, and it's not that we can snap our fingers and we have a vaccine. Even 2 years is very, very astonishing to get a vaccine. But I think we have to figure out how do we get on with our lives without disrespecting the virus, because sooner or later the virus will win wherever it is.
Based on your findings thus far, do you have a sense of what we might see in the next 3 to 6 months? Do you foresee a second or third wave?
So our rates are very, very low, as they have been declining consecutively. We haven't really fully analyzed our results from a phase 2, but even there, out of 2,500 people, we found perhaps just one person who was infected. So we have very low rates. Our challenge to keep the rates low. So unless we have a big influx in our community, and unless we fail to completely prevent these infections by doing inadequate contact tracing, we might be able to keep these rates very, very low all the way through till October. Now, after October and November, all bets are off, because we know the virus is very likely to resurge in November. And the other startling thing is that's why we need to follow the antibodies. Even the antibodies, the people who have antibodies, their immunity declines over 3 to 6 months. And so the people who've had the virus may again become susceptible in fall. So we need to keep track of that. So we believe that it's likely that the virus will reappear sometimes in October and November.
Aruni, do you want to just share briefly the collaboration we just completed with Johns Hopkins, looking at Northern Hemisphere countries and why we might think you would expect it to come back next winter?
Yes, thanks for reminding, Tad. So we just completed this paper we sent out for publication. We did the analysis from 55 different countries, and we found a strong linear relationship with temperature, right? So the more the temperature and the less the infection rates. And we're not very sure why that is. Two reasons could be contributing. First is temperature, of course. The virus is very sensitive to temperature. Second thing is sunlight. The UV is an excellent killer of the virus, and within 30 minutes to an hour, the virus would be dead in strong UV light. Then the third thing is humidity. So the more humidity we have, the less the spread of the spray. So even when we speak, if you have high humidity, the aerosol settles down very quickly. So even though countries which have hot climates, like or maybe India or Singapore, Vietnam, have high rates of the virus, they're still much, much, much lower than that have been in colder climates. So we think that the temperature is going to, if anything, attenuate the spread of the virus, but may not be able to protect us for November and December when it gets really cold.
Is this strain of the coronavirus as deadly as initially suspected?
So we don't know the strain that we have in Louisville. There are 3 different strains floating around. One is that came from Milan and Italy and Europe, and the other one is coming out of Wuhan in China. The European strain seems to be much more deadly, and the things that happen in New York, but one particular strain. We are in the process of collecting samples to see whether we have both the virus, because we're in the middle of the country. So we don't know whether we have both the strains or less strain. So that's another hope. There were some reports from Italy that the virus seems to be losing its virulence, and that the physicians, they were saying that 80, 90-year-olds who are getting infected actually are surviving, which was not happening in March. So it may be that the virus is gradually mutating. The virus undergoes 1 mutation per month. And so it could be, and that mutation is a random event. And it could be that just one of the mutations makes it less virulent or less lethal. So that can happen too. And that's probably likely what's going to happen. If we don't do anything, in a couple of years, the virus will just die away. But in the meantime, it would have killed millions of people. So we can't wait for that.
Mm-hmm. Well, those are all of the questions that we have from our guests, Dr. Bhatnagar and Dr. Smith. Unless either of you have something else you would like to share, I'll turn this back over to Dr. Bendapudi.
oops. All right. Any other questions from everybody? I thought every time Aruni and Ted, I learned something new about this. I knew that the virus mutates, but the idea that every month it's mutating, it's just we forget this is something that's going to be around, and we have to figure out how we live with this and what we do. While other people.
Dr. Neeli, I apologize. We just got one more question in, and I think it's an important question, so I want to share this. There's a lot of leading edge medical research being conducted at UofL now. What can we do to give more exposure so it can help move more people around the world, as well as what can we do to give and support this at UofL and its deserved recognition?
Whoever asked that question, may I send you a big virtual hug? We need your support. And I'll give you this context for it. There is an incredible amount of work that's happening.
I felt the hug, by the way, Neeli.
Thank you, Kevin.
I felt the hug. Thank you. I needed it.
So we definitely need your support. And I'll put this in context by giving you one little thing, which is that for us, I've told you that we're one of 130 research universities that are R1 in the whole world. The other challenge that we have that I want you to remember is that 40% of our students are on Pell Grants. So for other R1s, if I look at every other R1 I've been at, whether it's Ohio State or Kansas or Texas A&M, their numbers are about 10% of their students are Pell eligible. And UK, which is also an R1, has about 20% of their students who are Pell eligible. Pell eligible is like free and reduced lunch in schools, as you know. It's based on the family income. So we are an institution that is both doing incredible research and really transforming lives. We have a very, very large percentage of low-income and first-generation college students. So anything you can do to help is incredibly helpful. There is a link to the community project. Right now, one of the big things we want is for people to support this particular project. And I will tell you why. One, of course, is that it will advance research and it will help us. The second thing is just purely selfishly for our community, for Louisville and for the Commonwealth, whether it's when our students come back, being able to see whether through the wastewater research, we can see which dorm or which location we need to pay more attention to. There's just so many things that come into play. So we've given you a link, and regarding publicizing this more, Kevin, I think you're onto something. I was just thinking about this as we talk about it. I would like to do more of these where we invite other people, like maybe it's not really anything else except researchers. So you heard the Center for Predictive Medicine. If you heard from Dr. Ken Palmer, you would love it. It's a whole different area. But I think right now where we are, perhaps we do something else with Aruni and Ted, where it's just very few minutes of telling you what the research is, and then we answer more questions. I'm open to your suggestions too. I really think like today, this message, I want 50 more people to be listening to it because there's something of value that we could all take away with us. So I know that, Marianne, did you post it in the chat box? Good. So please spread the word. And as we always say, whatever you're able to do, time, talent, treasure, all of the above are desperately needed. So I would say that.
Dr. Bendapudi, it's Christy.
Yes, Brown.
Christy, please. It's so exciting to have this conversation with you and your team who are present. I'd love any thoughts, if not now, later, about how perhaps other disciplines could become engaged in this remarkable project. I'm so curious. I've been listening a lot now, and particularly to Sadiqa Reynolds, about her grave concern for the mental lack of the sort of psychological health of our community. And I've heard that from medical folks as well. So, are there psychological specialists at the university who could somehow come in and partner quickly with these various testings? And I'm sure you would think of other examples. But.
No, absolutely. In fact, it's interesting. We have a meeting. I don't know if it's already been set up because I made the introductions and had them meet, where our School of Education and our School of Social Work are collaborating along with some psychologists. Now there we're focusing on children, because COVID-19, where so many of them have been isolated, and for many of us with our kids being home, they're in safe places, they're in homes where they're loved. For a lot of them, that may or may not be the case. You know, that social isolation, what is it doing to them? And in fact, they are getting ready to do that study. And we had not thought about the mental wellness impact on adults, but we are starting with children. I don't see why we wouldn't expand it. The reason for starting with children, and it's still preliminary, but to start with JCPS so that schools will have an easy testing. So when the kids come back, it's not only about are they academically prepared, do we need to jumpstart because, you know, they've been away from the house, but how are they mentally? Are they ready for this? Do they need additional help? So yes, we are actually engaging in research along those lines.
Right, if I just add, Christy, we are actually collaborating with Dr. Patrick Posel, who's in the Department of Counseling and Human Development, and he is the director of the Cardinal Success Program, and we're doing a survey of the mental health of the people and the levels of stress that people are undergoing because of COVID-19 and how they're coping with it. So we actually have a very sort of large program plan that in the next round of our survey, we will ask people questions and see what they're doing. So, to the larger point, we need to collaborate with lots of other types of people because again, health is not just one thing. It's not just the virus and getting sick. We need to figure out all the other social and economic and cultural factors that are contributing to this pandemic.
Mm-hmm. Definitely. Other questions? I am just so delighted that you all are participating in this because a big challenge for me is making sure that people understand the unbelievable assets that we have at the University of Louisville and the difference that they're making. And so if this is a topic of interest, maybe as we think about COVID-19, back to what Christy asked, we could bring different pieces of the puzzle that people are working on and try to focus on how we at the University of Louisville are trying to make a difference. All right. I guess the secret to getting people to sign up is making sure we don't take up more of your time than we said. So we said 6 to 7 p.m. We have about 5 more minutes. Any closing thoughts? Marianne or the team, Ted, Aruni?
I'd love to ask Mary, if she's still with us, what the reaction of the board of directors of the university has been to this co-immunity project, and if Mary, you feel they are informed adequately, and if not, would it be a good idea to have a session like this with the board?
I hate to admit this, but Neeli and I have been texting about that during this session. Yeah, I mean, I know I've talked to a couple specifically about it. The Board of Trustees hasn't been together since April 3rd, maybe, and we have committee meetings tomorrow. But I think, this is one of those cases, the more you know, the more you care. And every time I sign up for one of these things, I learned so much. And I do think that it's something we need to have. You know, we could have a session with just the Board of Trustees, or we could just include them in whatever next session is presented.
Do you still have your Board of Overseers, Mary?
We changed the name.
But we don't call it that anymore.
Oh, what do you call it?
The President's Council.
Oh, cool.
Thank you, Mary. My board chair, confessed that the two of us were texting about just that. I was saying, what we will do is maybe for our board, but actually we have so many boards. I'd like to, by invitation, have all of our board members that are available join us so that they learn more about the co-immunity project. So Mary knows a lot about this and is always championing this. So.
Yeah, I think certainly the university does a good job of keeping us informed in all of these initiatives, but hearing directly from Dr. Bhatnagar and from Ted is, pretty powerful.
Agreed.
Though I did have to chuckle Aruni, when you said that you take your crazy ideas to Ted Smith because he's just as crazy as you are.
No, that's okay. That's part of the magic of the way this works.
2 minuses make a plus.
So
But
far.
I do want to thank Neeli for her support and everything she's done. Neeli, without your help and input, we would not have gotten this off ground. Initially, I mean, yeah, so this is not something that we can do as this is one person's credit. This is our entire team, and the sort of environment and the background that you created, the university with your leadership, has been immensely powerful in trying to get such projects off ground and be doing something meaningful, which is both meaningful academically and in terms of the community. So I think we should keep on the path, and thank you for leading us through all of this.
Absolutely. Thank you. The least that I can do. So everybody, you have on 3, you're going to say go cards, and you're going to say thank you to Aruni and to Ted. And of course, you are definitely going to say thank you to Christina Lee Brown. You ready? We're going to do go cards, and that means thank yous to everybody. 1, 2, 3.
Go Cards.
All right. Can you take a picture, somebody?
Yes, if you'll give me just a second, I can take care of that for you.
All right. Ted? All right. Oh, Todd is here. Awesome. Tiffany. All right.
Yeah.
There we go. Everybody will just hold them up for a quick second. All right, we'll get that taken care of.
Thank you so much, everybody. Be safe.
Thank you.
And until next time.
All right.
Thanks, Neeli.
Jeff.
Thank you.